Neurology of Fear is a medical documentary series presenting clinically documented neurologic and pathological mechanisms for educational analysis.
The neurology exam room is quiet, except for the sound of paper being pulled across the doctor's table. A teenager sits on an examination table with their shoes removed, feet hanging slightly above the floor. The neurologist asks them to walk across the room and turn. The first steps are careful, deliberate, wider than expected. The turn is slower. The heel does not land in a straight line. There is no pain reported. There is no dizziness. The patient is alert, oriented, answering questions without hesitation. School performance is average to above average. Speech is clear in conversation. On paper, this looks like a minor coordination issue. In the room, it looks like something that has already been present for years without being named. The medical chart shows a pattern that has not triggered urgency. Missed steps during sports. Difficulty keeping balance on uneven ground. Handwriting that has gradually become less precise. Physical education teachers noting clumsiness rather than weakness. Parents reporting that the patient avoids running but does not complain of fatigue in other contexts. There are no tremors at rest, no seizures, no headaches, no emotional lability. Vital signs are normal. The patient has grown normally. Puberty has progressed on time. There is nothing in the room that suggests acute illness or systemic disease. The neurologist begins a standard examination. Finger-to-nose testing is slow. The finger overshoots the target and corrects late. Rapid alternating movements are uneven. Reflex testing shows diminished responses in the lower limbs. When asked to stand with feet together and eyes closed, the patient sways immediately and opens their eyes to regain balance. There is no complaint of numbness. There is no reported weakness. Muscle bulk appears preserved. Strength testing is near normal. What is failing is not force, but coordination and positional control. At this stage, the condition is often misclassified. It is not anxiety. The patient is calm and cooperative. There is no panic response. It is not a behavioral disorder. Attention is intact. Instructions are followed accurately. It is not lack of effort. The movements are attempted with full engagement. It is not deconditioning. The patient participates in daily activities and has not been sedentary. It is not a primary psychiatric condition. There are no mood disturbances driving motor behavior. These exclusions are critical because the early presentation does not look dramatic. It looks incomplete. Over the next months, the changes continue. Walking requires more concentration. Uneven surfaces become hazardous. Stairs are approached cautiously. The patient begins to look down while walking, relying on visual input to guide foot placement. Falls are rare, but near falls are frequent. Speech begins to change subtly. Words are pronounced correctly, but timing is altered. Syllables are spaced irregularly. Listeners describe it as slurred, but language content remains intact. There is no word-finding difficulty. There is no memory loss. The patient is fully aware of the changes but cannot correct them through practice. At this point, imaging is often ordered. Magnetic resonance imaging of the brain may show minimal changes or appear normal in early stages. There is no mass lesion, no demyelinating plaques, no evidence of stroke. Blood work returns unremarkable. Vitamin levels are normal. Thyroid function is normal. There is no evidence of infection or autoimmune disease. The absence of clear findings delays definitive diagnosis. The progression continues during this period of uncertainty. The condition is not stress-related. Stress does not selectively reduce reflexes in the lower limbs. It does not impair rapid alternating movements while sparing strength. It does not produce progressive gait ataxia in adolescence with preserved cognition. It is not aging. The patient is young. It is not a consequence of lifestyle. Diet and activity level do not account for the pattern. These clarifications matter because the disease progresses during misclassification and the underlying pathology does not pause. The first definitive clue often comes from the distribution of deficits. Lower limb involvement precedes upper limb involvement. Balance fails before strength. Reflexes diminish rather than increase. Sensory complaints are minimal early. despite clear proprioceptive instability. This combination points away from cortical disease and towards subcortical and spinal systems involved in coordination and sensory integration. The cerebellum becomes a focus of concern, not as an isolated structure but as part of a broader network. Only after this pattern is recognized does the biological cause enter the discussion. Friedreich's ataxia is named not as a descriptive label, but as a specific genetic condition with a defined molecular origin. It is an autosomal recessive disorder caused by an expansion of a trinucleotide repeat sequence within the FXN gene. This expansion does not produce a toxic protein, it reduces gene expression. The result is a deficiency of frataxin, a protein essential for mitochondrial function. Frataxin is not a signaling molecule. It does not act at synapses. It operates within mitochondria, where it regulates ion handling and the assembly of iron-sulfur clusters. These clusters are required for multiple enzymes within the electron transport chain. Without adequate frataxin, mitochondria accumulate iron that cannot be properly utilized. Electron transport becomes inefficient. Reactive oxygen species increase. ATP production declines. This failure is intracellular, metabolic, and progressive. Neurons with high energy demands are affected first. The dorsal root ganglia, cerebellar dentate nucleus, spinocerebellar tracts, and corticospinal pathways rely on sustained mitochondrial output. These neurons have long axons and limited capacity to switch to alternative energy sources. As frataxin levels remain low from early development, mitochondrial stress accumulates over years rather than days. Cells function below optimal thresholds long before they fail outright. In the cerebellum, the dentate nucleus plays a central role in coordinating motor output. It integrates signals from Purkinje cells and relays them to motor and premotor cortex via the thalamus. In Friedreich's ataxia, neurons within the dentate nucleus undergo gradual degeneration. This is not an inflammatory process. There is no acute cell death wave. There is chronic energy insufficiency, leading to cellular dysfunction and eventual loss. As dentate nucleus output weakens, timing information sent to the cortex becomes unreliable. Motor commands are generated normally, but lack precise temporal calibration. Movements overshoot or undershoot targets. Corrections are delayed. This explains why strength testing remains near normal while coordination fails. The motor system can still activate muscles, but it cannot synchronize them effectively. Simultaneously, the dorsal columns of the spinal cord begin to degenerate. These pathways carry proprioceptive information from the periphery to the brain. As they fail, the brain loses accurate information about limb position. The patient compensates by relying on vision. This is why balance deteriorates dramatically when eyes are closed. The instability is not psychological. It is a consequence of missing sensory data. Peripheral nerves are also affected. Large myelinated sensory fibers degenerate, leading to loss of vibration sense and joint position sense before pain or temperature sensation. Reflex arcs are disrupted, resulting in diminished or absent reflexes. These changes further impair movement regulation. The motor system is now operating with degraded input and degraded coordination output simultaneously. Throughout this progression, cognition remains largely preserved. The cerebral cortex is relatively spared early. The patient understands instructions, perceives deficits, and attempts to adapt. This preserved awareness becomes a defining feature of the disease. The individual can identify errors but cannot prevent them through conscious control. Practice does not restore lost circuitry. Repetition increases metabolic demand without correcting the underlying mitochondrial failure. The diagnosis is eventually confirmed through genetic testing. Expanded GAA repeats within the FXN gene are identified on both alleles. This confirms the absence of sufficient frataxin production. At this point, the disease has already altered multiple systems. The confirmation does not change the trajectory, it names it. From this point forward, progression is expected, not optional. This is the earliest stage at which Friedreich's ataxia is recognized as a single, unifying condition. What began as subtle imbalance is now understood as a systemic mitochondrial disorder with selective vulnerability of coordination circuits. The mechanisms are in place. The losses observed so far are the first outward signs of a process that will continue to dismantle motor regulation, sensory integration, and eventually autonomic and cardiac function. The patient remains alive, aware, and engaged. The systems that translate intention into controlled action are already failing. Frataxin deficiency does not announce itself with sudden failure. From birth, cells operate with a reduced margin of metabolic safety. The FXN gene remains transcriptionally silenced by the expanded GAA repeats, limiting frataxin production in every cell. There is no period of normal abundance followed by loss. The nervous system develops under chronic constraint, compensating until compensation is no longer sufficient. Within mitochondria, iron handling becomes progressively disorganized. Iron is imported into the organelle as usual, but without adequate frataxin, it cannot be efficiently incorporated into iron-sulfur clusters. These clusters are required cofactors for enzymes in complexes I, II, and III of the electron transport chain. When cluster assembly fails, these enzymes lose functional capacity. Electrons leak, reactive oxygen species increase. ATP yield per glucose molecule declines. The cell remains alive but energetically unstable. This instability is unevenly distributed. Tissues with low baseline energy demand tolerate the deficiency longer. Cells with high and continuous ATP requirements accumulate damage. Neurons are particularly vulnerable because they rely on oxidative phosphorylation almost exclusively and cannot downregulate activity without losing function. Long axons further increase energy demand due to the need for active transport over extended distances. The dorsal root ganglia, cerebellar nuclei, and spinal tracts are therefore among the first structures to show dysfunction. Importantly, this is not a disorder of protein aggregation. There are no misfolded inclusions overwhelming cellular clearance systems. It is not a synaptic receptor disease. Neurotransmitter release and receptor binding remain largely intact early. The failure occurs upstream at the level of cellular power generation. Neurons fire with less precision because the energy required to maintain ion gradients, axonal transport, and synaptic timing is insufficient. This leads to subtle errors that accumulate over time. Iron accumulation within mitochondria introduces additional stress. Free iron catalyzes the formation of hydroxyl radicals through Fenton chemistry. These radicals damage mitochondrial DNA, lipids, and proteins. Mitochondrial DNA damage further impairs respiratory chain components, creating a feedback loop. As damage accumulates, mitochondrial biogenesis cannot compensate because frataxin deficiency persists. New mitochondria inherit the same vulnerability. In the dentate nucleus of the cerebellum, neurons are densely packed and metabolically active. They integrate inhibitory input from Purkinje cells and generate excitatory output to thalamic targets. This output is essential for timing and scaling of movement. As mitochondrial dysfunction progresses, dentate neurons exhibit reduced firing reliability. Action potentials become irregular. Synaptic output loses temporal precision. The neuron remains present, but its contribution to the circuit is degraded. This degradation does not produce immediate cell death. Instead, it produces circuit noise. Motor commands arriving from the cortex are no longer matched with accurate timing signals from the cerebellum. The result is movement that is initiated correctly, but executed inaccurately. Overshoot, undershoot, and delayed correction appear. These features are hallmarks of cerebellar involvement and are among the earliest clinical signs. Parallel processes occur in the dorsal root ganglia. These sensory neurons convey proprioceptive information from muscle spindles and joint receptors. They are large, myelinated, and energetically demanding. As mitochondrial function declines, these neurons lose the ability to sustain high-frequency signaling. Sensory input becomes delayed and degraded. The brain receives incomplete information about limb position. This loss is not immediately perceived as numbness. Instead, it manifests as instability when visual cues are removed. The spinal cord pathways that relay this information also degenerate. The dorsal columns, which carry fine touch and proprioception, show axonal loss. Spinocerebellar tracts, which provide real-time feedback to the cerebellum, are similarly affected. This compounds cerebellar dysfunction. The cerebellum is now attempting to coordinate movement with both impaired internal processing and impaired external feedback. Throughout this period, the patient may attempt to adapt. Movements are slowed to increase accuracy. Visual attention is increased to compensate for lost proprioception. These strategies temporarily improve function, but increase cognitive load and metabolic demand. They do not repair damaged mitochondria. They do not restore frataxin levels. As the disease progresses, compensation becomes less effective. The peripheral nervous system is not spared. Large fiber sensory neuropathy develops as axons degenerate. Reflex arcs are disrupted because afferent signals cannot be reliably transmitted. This explains the early loss of deep tendon reflexes despite preserved muscle strength. The motor neurons themselves are initially intact. They receive commands and can activate muscle fibers. The problem lies in coordination and feedback, not in muscle activation. At the cellular level, there is no inflammatory response driving this process. Microglial activation is minimal early. There is no autoimmune attack. This absence of inflammation contributes to diagnostic delay. Standard markers of neuroinflammation are not elevated. Cerebrospinal fluid studies may appear normal. The disease progresses quietly, driven by metabolic insufficiency rather than immune-mediated damage. As mitochondrial dysfunction persists, cells begin to cross thresholds of viability. When ATP production falls below the level required to maintain ion gradients, neurons become susceptible to excitotoxic stress. Calcium handling is impaired. Mitochondrial permeability transitions occur more readily. Over time, this leads to apoptosis or necrosis of vulnerable neurons. Once lost, these neurons are not replaced. The adult nervous system does not regenerate complex circuits. The genetic nature of Friedreich's ataxia ensures that this process is continuous. There is no environmental trigger to remove. There is no immune response to suppress. Frataxin levels remain low throughout life. Therapeutic interventions aimed at increasing mitochondrial efficiency can slow progression, but cannot restore normal function once neurons are lost. The disease trajectory is set at the molecular level. As the cerebellar dentate nucleus continues to degenerate, its output to the thalamus weakens further. Thalamocortical communication becomes less synchronized. The motor cortex receives distorted timing signals. Speech production, which relies on rapid coordination of respiratory, laryngeal, and articulatory muscles, becomes affected. Dysarthria develops. Words are correctly chosen, but poorly timed. The patient remains aware of speech errors and attempts correction, often without success. This awareness distinguishes Friedreich's ataxia from conditions that impair cognition early. The patient can describe their deficits accurately. They can anticipate difficulty and plan around it. What they cannot do is restore lost coordination through intention alone. The failure lies in the circuitry that translates intention into controlled action. That circuitry is being dismantled at a cellular level. By the end of this phase, the disease has established itself across multiple levels of the nervous system. Mitochondrial dysfunction is entrenched. Iron accumulation continues. Neuronal populations critical for coordination and sensory integration are compromised. The patient is still ambulatory, still communicative, still cognitively intact. The systems that support independent movement and precise control are operating with diminishing reliability. This sets the stage for the next phase of progression, where cerebellar circuit failure becomes the dominant clinical feature, and compensatory strategies are no longer sufficient to maintain functional independence. The underlying pathology does not accelerate dramatically. It remains steady, persistent, and irreversible, advancing through systems that depend on sustained mitochondrial energy to function. As degeneration advances, cerebellar involvement becomes the dominant driver of disability. The cerebellum does not generate movement, it calibrates it. It predicts the sensory consequences of motor commands and adjusts output in real time. This function depends on precisely timed signaling between Purkinje cells, deep cerebellar nuclei, the inferior olive and thalamocortical relays. In Friedreich's ataxia, this timing architecture collapses because its most energy-dependent nodes fail first. Purkinje cells receive vast synaptic input and fire at high baseline rates. Their inhibitory output shapes the activity of neurons in the dentate nucleus. When mitochondrial dysfunction compromises Purkinje cell metabolism, firing becomes irregular. The pattern of inhibition loses consistency. Dentate neurons, already vulnerable due to their own metabolic demands, receive distorted input. Their output to the thalamus becomes unreliable, not absent, but poorly timed. This loss of temporal precision disrupts cerebellar contribution to motor planning. Movements are initiated without accurate prediction of their outcome. Error correction is delayed because feedback loops are slowed by both cerebellar and spinal pathway degeneration. The result is dysmetria. The hand reaches too far, then corrects late. The foot lands off target, then shifts. These corrections are conscious but ineffective at restoring smooth movement. The inferior olive, which provides climbing fiber input essential for motor learning, also becomes dysregulated. Its neurons rely on synchronized oscillatory activity to signal errors and adjust cerebellar output. As mitochondrial stress accumulates, this synchrony degrades, motor learning slows. Tasks that once improved with repetition no longer do. Practice increases effort, but not accuracy. The cerebellum loses its ability to update internal models of movement. Clinically, gait becomes more unstable. Steps widen further. Turns require multiple small adjustments. The patient may appear cautious, but the caution does not prevent missteps. Falls become more frequent, especially in low light conditions where visual compensation is limited. Assistive devices are introduced not because of weakness, but because coordination can no longer be trusted to maintain balance. Speech changes become more apparent. Dysarthria progresses as timing between respiratory effort, vocal cord movement, and articulation deteriorates. Volume may fluctuate. Consonants may be imprecise. The patient knows what they want to say and can construct complex sentences, but the mechanical execution is impaired. Listeners may misinterpret this as cognitive decline, but comprehension and expression at the language level remain intact. Eye movements are also affected. The cerebellum plays a critical role in coordinating saccades and smooth pursuit. As circuits degrade, saccades overshoot targets and require corrective movements. Smooth pursuit becomes jerky. Reading becomes fatiguing. Visual tracking during movement is less reliable, further compromising balance and coordination. At this stage, adaptation strategies fail more quickly. Slowing movement no longer restores accuracy because timing errors persist regardless of speed. Visual monitoring cannot fully compensate because eye movement coordination is also impaired. The patient expends increasing cognitive effort to perform basic tasks. This effort does not improve outcome. It increases fatigue. Diagnostic imaging may now reveal cerebellar atrophy, particularly in the dentate nucleus. This finding confirms structural loss that was previously inferred from function. However, imaging does not capture the full extent of circuit disruption. Many neurons remain present but dysfunctional. Their metabolic capacity is insufficient to sustain reliable signaling. This distinction matters because it explains why symptoms can be severe even when gross atrophy appears modest. The progression remains bilateral and symmetric. There is no focal lesion to target. No surgical intervention can restore lost circuitry. Pharmacologic treatments aimed at modulating neurotransmission offer limited benefit because the primary failure is energetic, not synaptic. Attempts to enhance mitochondrial function may slow further loss, but cannot restore neurons that have already crossed viability thresholds. As cerebellar output continues to weaken, its influence on cortical motor areas diminishes. The motor cortex generates commands without accurate calibration. Movements become fragmented. Tasks that require fine motor control, such as writing or buttoning clothing, become difficult or impossible. The patient adapts by using gross movements, but these too become unreliable. Importantly, this progression does not involve loss of motivation or understanding. The patient remains engaged in their care. They recognize decline. They plan around it. The frustration that may be observed is secondary to repeated failure of execution, not a primary emotional disorder. The nervous system is failing to translate intention into action. By this point, the cerebellum is no longer a reliable regulator of movement. Its circuits have been dismantled by chronic mitochondrial insufficiency. The failure is stable in its direction. There is no spontaneous recovery. The disease continues to advance into additional systems that rely on the same vulnerable metabolic infrastructure. As cerebellar regulation deteriorates, the spinal cord becomes the next major site where functional failure accumulates. The spinal cord is not a passive conduit. It integrates descending motor commands with ascending sensory information to produce coordinated movement. In Friedreich's ataxia, this integration fails because the pathways responsible for carrying proprioceptive and coordination signals degenerate in parallel with cerebellar circuits. The dorsal columns are among the earliest spinal tracts affected. These columns carry fine touch and proprioceptive information from the periphery to the brainstem and cerebellum. Large diameter, heavily myelinated axons dominate these pathways. Their metabolic demands are high. As mitochondrial dysfunction persists, axonal transport slows. Myelin maintenance becomes inefficient. Axons thin, fragment, and are eventually lost. The signal does not stop abruptly. It degrades, becoming delayed and unreliable before disappearing. Clinically, this loss manifests as impaired position sense rather than numbness. The patient may not report sensory loss when asked directly. They can feel light touch. They can detect temperature. What they cannot do is accurately perceive where their limbs are in space without looking. This deficit becomes apparent during balance testing and complex movements. It explains why standing with eyes closed is disproportionately difficult. Vision becomes a compensatory input, not because vision is enhanced, but because proprioception is failing. Spinocerebellar tracts, which carry real-time sensory feedback to the cerebellum, also degenerate. These tracts are critical for updating cerebellar predictions during movement. As they fail, the cerebellum loses access to peripheral feedback. Even if some cerebellar neurons remain functional, they are operating without accurate input. The system becomes increasingly disconnected, with each remaining component deprived of the information it needs to function. Descending motor pathways are affected later, but their integrity does not preserve function. Corticospinal tracts may initially remain structurally intact, allowing voluntary movement to continue. However, without cerebellar calibration and spinal sensory integration, these commands produce poorly coordinated output. Muscle activation occurs out of sequence. Agonists and antagonists are not properly timed. The result is movement that is effortful and inefficient, even when strength testing appears preserved. Peripheral nerves contribute additional failure. Large fiber sensory neuropathy progresses as axons degenerate distally. Vibration sense diminishes. Joint position sense becomes unreliable. Reflex arcs are disrupted because afferent input cannot reach the spinal cord effectively. Deep tendon reflexes disappear, not because motor neurons are lost, but because the sensory limb of the reflex is interrupted. This loss removes an additional layer of automatic postural correction. As these changes accumulate, the patient experiences a specific form of loss of control. They can initiate movement. They can decide to stand, walk, or reach. The command is issued from the cortex. Execution fails at multiple downstream points. The spinal cord cannot integrate the command with accurate sensory feedback. The cerebellum cannot correct timing errors. The peripheral nerves cannot reliably report limb position. The result is movement that feels disconnected from intention. This disconnection becomes most apparent during transitions. Standing from a seated position requires precise coordination of trunk and limb muscles. Without reliable proprioceptive input and cerebellar timing, the movement becomes unstable. The patient may overshoot, undershoot, or require external support. These failures are not random. They reflect specific circuit deficits that worsen predictably over time. Walking becomes increasingly unsafe. The patient widens their base further, steps shorten. Turning requires multiple corrective movements. Assistive devices become necessary, not because the legs are weak, but because the neural infrastructure required to coordinate them is compromised. Falls occur despite caution. Environmental hazards that were previously manageable become dangerous. Upper limb function also deteriorates. Reaching for objects requires visual guidance. Fine motor tasks become slow and inaccurate. Writing becomes illegible, not due to tremor, but due to inconsistent muscle activation timing. The patient may abandon tasks that require precision, not because of disinterest, but because repeated failure makes success unpredictable. Throughout this progression, muscle bulk may remain relatively preserved. Electromyography may show normal motor unit potentials early. This can be misleading. The absence of primary muscle disease or motor neuron loss delays recognition of the severity of the neurological failure. The problem is not force generation, it is regulation. Autonomic fibers within peripheral nerves may also become affected. Orthostatic intolerance can develop as cardiovascular reflexes weaken. Bladder function becomes less reliable. These features often appear later, but their presence signals that degeneration is extending beyond purely somatic pathways. The disease is no longer confined to coordination circuits. It is spreading into systems responsible for automatic regulation. The cumulative effect of cerebellar, spinal, and peripheral degeneration is a progressive narrowing of reliable motor capacity. Each remaining ability requires more conscious effort and more external support. The nervous system is no longer able to automate basic functions. Tasks that once required no attention now demand constant monitoring, and even then success is not guaranteed. This stage represents a critical shift. The patient is no longer losing isolated skills. They are losing the infrastructure that allows skills to be combined into independent action. The progression remains steady. There is no inflammatory flare, no sudden collapse. The failure is structural and metabolic, advancing as long as frataxin deficiency persists. Beyond this point, additional systems with high mitochondrial demand begin to show clinically significant involvement. The disease extends into cardiac and autonomic domains, introducing risks that are not directly related to coordination, but are driven by the same underlying mitochondrial failure. As neurological degeneration progresses, systems outside the cerebellar and spinal coordination networks begin to fail in clinically significant ways. These systems are not affected incidentally. They share the same vulnerability to chronic mitochondrial dysfunction driven by frataxin deficiency. Among them, cardiac tissue, autonomic circuits, and endocrine regulation become progressively compromised, extending the disease beyond movement into physiological regulation. Cardiomyocytes depend almost entirely on oxidative phosphorylation. Their continuous contractile activity requires uninterrupted ATP availability. In Friedreich's ataxia, mitochondrial ion accumulation disrupts electron transport in these cells, just as it does in neurons. Iron-sulfur cluster synthesis declines, oxidative stress increases, and ATP production becomes inefficient. In response, cardiomyocytes hypertrophy, increasing muscle mass to preserve contractile force despite declining metabolic efficiency. This adaptive hypertrophy is initially compensatory. Ventricular walls thicken. Systolic function may remain preserved. Over time, however, diastolic filling becomes impaired. The heart stiffens. Electrical conduction pathways, composed of metabolically active cells, become unstable. Arrhythmogenic risk increases as mitochondrial dysfunction compromises ion channel regulation and impulse propagation. Cardiac involvement often develops silently. Neurological disability dominates clinical attention, while structural cardiac changes progress without overt symptoms. Echocardiography may reveal hypertrophy before the patient reports exertional intolerance. Electrocardiographic abnormalities may appear intermittently. Despite monitoring and treatment, the underlying pathology continues because frataxin deficiency persists in every cardiomyocyte. Endocrine regulation is affected through similar mechanisms. Pancreatic beta cells rely on mitochondrial ATP generation to couple glucose sensing to insulin release. As mitochondrial efficiency declines, insulin secretion becomes dysregulated. Diabetes mellitus develops in a subset of patients, often during adolescence or early adulthood. This metabolic instability is not driven solely by insulin resistance. It reflects impaired cellular signaling linked directly to mitochondrial failure. Autonomic nervous system involvement introduces additional instability. Autonomic neurons require sustained metabolic output to regulate cardiovascular reflexes, bladder control, gastrointestinal motility, and thermoregulation. As these neurons degenerate, autonomic regulation becomes unreliable. Orthostatic hypertension may emerge as baroreflex circuits fail. Heart rate and vascular tone no longer adjust appropriately during postural changes. Bladder function becomes inconsistent. Urgency, retention, or incomplete emptying may occur. Gastrointestinal motility slows, leading to constipation. Temperature regulation becomes less precise. Sweating patterns may change. These features are not psychological or secondary. They indicate that degeneration has extended into automatic regulatory systems that operate outside conscious control. As these systemic failures accumulate, a deeper neurological deficit emerges that cannot be explained by coordination loss alone. The nervous system begins to lose the ability to initiate action reliably. This failure is not due to weakness, lack of motivation, or impaired understanding. It reflects breakdown of preparatory motor and autonomic circuits required to transition intention into execution. Voluntary movement initiation depends on coordination between the supplementary motor area, premotor cortex, basal ganglia, cerebellum, and brainstem. These networks establish timing, sequencing, and physiological readiness before movement occurs. In Friedreich's ataxia, degraded cerebellar output disrupts this preparatory signaling. The supplementary motor area receives incomplete timing information, preventing stable motor plans from forming. Basal ganglia circuits, which gate initiation and suppress competing motor programs, become inefficient without reliable cerebellar input. Multiple motor programs may be partially activated without one being selected cleanly. This produces hesitation, delayed starts, and aborted movements. The patient may pause before standing, hesitate before walking, or struggle to initiate speech despite intact language formulation. Autonomic initiation fails in parallel. Normal movement requires anticipatory cardiovascular and respiratory adjustments. Heart rate increases before standing. Blood pressure stabilizes through reflex vasoconstriction. Respiratory patterns adjust before speech. As cerebellar and brainstem integration degrades, these preparatory adjustments lag or fail entirely. Movement begins without adequate physiological support, leading to lightheadedness, instability, or fragmented speech output. These failures become consistent rather than episodic. External cues such as verbal prompting, visual signals, or physical assistance may temporarily facilitate initiation, but do not restore autonomy. The nervous system can still respond to stimuli, but it can no longer reliably generate action from internal intent alone. This represents a biological loss of authorship over movement and regulation. Management at this stage remains supportive. Cardiac medications reduce arrhythmia risk. Endocrine therapy manages glucose levels. Physical therapy preserves remaining mobility. None of these interventions restore lost preparatory circuitry. The disease continues to advance at a cellular level, narrowing the margin between preserved intent and declining execution. From a developmental standpoint, the neurological failure seen in Friedreich's ataxia is not a late-onset breakdown, but a delayed consequence of lifelong metabolic constraint. Frataxin deficiency is present from embryogenesis. Every neuron develops under conditions of reduced mitochondrial reserve. What distinguishes this disorder is not the presence of early damage, but the nervous system's prolonged ability to compensate before failure becomes clinically visible. During childhood, neural circuits prioritize growth, synaptogenesis, and gross functional acquisition. Energy demand fluctuates rather than remaining constant. Mitochondrial inefficiency is tolerated because developing systems rely on redundancy and plasticity. Motor milestones are achieved. Balance appears adequate. Speech develops normally. These early successes mask the underlying constraint because compensation is still biologically affordable. As maturation progresses, neural systems transition from growth to maintenance. Circuits stabilize. Axonal transport becomes continuous. Ion gradients must be maintained without interruption. Synaptic timing must remain precise over decades rather than minutes. At this stage, mitochondrial reserve becomes non-negotiable. In Friedreich's ataxia, that reserve does not exist. The nervous system crosses an energetic threshold it cannot sustain. This transition explains the characteristic latency between genetic cause and clinical onset. The disease does not activate. It is unmasked when long-term energetic demand exceeds capacity. The nervous system is not attacked. It is slowly outpaced by its own requirements. Selective vulnerability emerges from this mismatch. Dentate nucleus neurons fire continuously and integrate dense inhibitory input. Their calcium handling is metabolically expensive. Small reductions in ATP availability disrupt buffering and spike timing. These neurons do not fail catastrophically. They lose precision. Output becomes unreliable long before the cell dies. Dorsal root ganglion neurons share a parallel vulnerability. Their axons span extreme distances. Maintaining axonal transport under chronic mitochondrial stress becomes progressively inefficient. Distal segments degenerate first. Sensory information degrades before sensation disappears. The patient does not feel numb. They lose positional certainty. Cortical neurons are spared early because they possess greater metabolic flexibility and redundancy. Executive function, language formulation, and memory remain intact. This dissociation is central to the disease's psychological burden. The individual remains fully aware of deficits they cannot correct through effort or learning. As degeneration advances, the nervous system enters a phase defined not by loss of intent, but by loss of reliability. Commands are issued correctly but executed inconsistently. Identical movements produce different outcomes. This variability reflects unstable circuit performance rather than fluctuating motivation or attention. This pattern distinguishes Friedreich's ataxia from inflammatory, motor neuron, and dopaminergic disorders. There are no relapses, no remissions, no primary weakness, no tremor-dominant rigidity. The failure is structural, metabolic, and cumulative. By the time cerebellar, spinal, and peripheral pathways are all compromised, compensation no longer stabilizes function. Remaining neurons operate near energetic limits. Additional effort accelerates fatigue without restoring control. The system has narrowed to a reduced but stable operating range. It is at this stage, after compensation fails, but before complete systemic collapse, that the disease becomes irreversible in a functional sense. As cerebellar degeneration progresses, the most critical failure is not loss of movement generation, but loss of prediction. The cerebellum does not initiate action. It constructs internal models that allow the nervous system to anticipate the sensory consequences of movement before those movements occur. This predictive function is what allows motion to feel smooth, intentional, and controlled. At the center of this system is the cerebellar microcircuit. Purkinje cells receive convergent input from parallel fibers carrying contextual information and climbing fibers carrying error signals. Their inhibitory output regulates the firing of neurons in the deep cerebellar nuclei, particularly the dentate nucleus. This output is precisely timed. Millisecond-level accuracy is required to synchronize motor commands with predicted sensory feedback. In Friedreich's ataxia, this timing architecture collapses gradually. Purkinje cells remain present but metabolically compromised. Their baseline firing becomes irregular. Inhibitory signals arrive late, early, or inconsistently. Dentate nucleus neurons receive distorted input and respond with unreliable output. The cerebellum does not go silent. It becomes noisy. This noise is not random. It reflects loss of predictive precision. The cerebellum can no longer calculate the expected outcome of a movement before it occurs. As a result, motor commands are issued without accurate anticipation. Corrections are forced to occur after the fact, once sensory feedback arrives. By then, the movement has already deviated from its intended path. This explains the defining clinical features of Friedreich's ataxia. Movements overshoot because prediction fails. Corrections are delayed because feedback pathways are degraded. Repeated attempts do not improve performance because learning depends on intact climbing fiber signaling, which is itself metabolically vulnerable. Practice increases effort, not accuracy. The inferior olive plays a critical role in this failure. Its neurons generate synchronized oscillations that signal motor error and drive adaptive change in Purkinje cell output. These oscillations depend on precise calcium handling and sustained ATP availability. In frataxin deficiency, inferior olivary neurons lose synchrony. Error signals degrade. The cerebellum loses its capacity to recalibrate. Without reliable error signaling, motor learning stalls. Tasks that once improved through repetition no longer do. The nervous system cannot update internal models because the circuitry responsible for detecting and encoding error has failed. This is why physical therapy preserves function only temporarily and cannot restore lost coordination. As predictive failure worsens, movement becomes increasingly dependent on conscious monitoring. The patient watches their limbs. They slow down deliberately. They plan each step. These strategies temporarily reduce error by bypassing automated prediction. However, they dramatically increase cognitive load and fatigue. Conscious control cannot replace millisecond-level cerebellar computation. This reliance on conscious oversight explains why dual tasking becomes impossible. Walking while speaking, turning while carrying an object, or navigating uneven terrain overwhelms remaining capacity. The nervous system can perform one task at a time, but cannot integrate multiple streams of information simultaneously. Automation is lost. Eye movement control deteriorates through the same mechanism. Saccades require predictive timing to land accurately on targets. Smooth pursuit requires continuous adjustment based on anticipated target motion. As cerebellar prediction fails, saccades overshoot and require correction. Pursuit becomes segmented. Visual tracking degrades, further destabilizing balance. Speech is affected because articulation depends on rapid sequencing of respiratory, laryngeal, and orofacial muscle effects. Each syllable must be predicted before execution. When prediction fails, timing collapses. Speech remains linguistically intact but mechanically distorted. Dysarthria emerges without aphasia. Importantly, this failure does not originate in the motor cortex. Cortical motor plans remain coherent. Intent is preserved. Command generation is intact. What is lost is the downstream predictive infrastructure that allows those commands to be executed smoothly. The nervous system knows what it wants to do. It cannot predict how to do it. This distinction is critical for medical authority. Friedreich's ataxia is not a disorder of weakness, motivation, or cognition. It is a disorder of predictive motor control caused by metabolic failure of cerebellar microcircuits. The fear it generates is rooted in preserved awareness, combined with irreversible loss of automation. As cerebellar noise increases, the system reaches a tipping point. Remaining neurons cannot synchronize because there are too few intact nodes to sustain coherent timing. Prediction fails globally. Movement becomes reactive rather than anticipatory. At this stage, compensation no longer stabilizes function. The nervous system has lost its ability to model itself. This marks the transition from progressive dysfunction to irreversible failure. The point of no return in Friedreich's ataxia is reached when cumulative cellular loss eliminates the nervous system's capacity to respond to intervention. This threshold is not defined by symptom severity alone. It is defined by irreversible structural disassembly of circuits required for regulation, coordination, and initiation. In the cerebellum, this threshold corresponds to critical depletion of neurons within the dentate nucleus. Once neuronal density falls below a functional minimum, remaining neurons cannot generate coherent output. Synchronization fails, because there are insufficient nodes to sustain timing signals. Even if frataxin levels were restored in surviving cells, the circuit lacks the architecture required to transmit calibrated information. In the spinal cord, degeneration of dorsal columns and spinocerebellar tracts reaches a similar threshold. Axonal transport removes physical conduction pathways. Myelination cannot be restored without axons. Proprioceptive information from the periphery no longer reaches the brain reliably. Visual input cannot substitute for continuous sensory feedback during movement. Commands are issued without awareness of limb position, making independent movement inherently unsafe. Peripheral nerve loss further solidifies irreversibility. Sensory neurons in dorsal root ganglia do not regenerate in sufficient numbers to restore feedback. Reflex arcs remain permanently disrupted. Automatic postural responses do not return. The nervous system must operate without foundational regulatory mechanisms that normally function outside conscious awareness. Cardiac tissue also reaches an irreversible state. Hypertrophic cardiomyopathy progresses to myocardial fibrosis. Fibrotic tissue does not conduct electrical impulses or contribute to contraction. Arrhythmogenic risk persists because conduction pathways are structurally interrupted. Even if mitochondrial function were improved in surviving cardiomyocytes, fibrotic regions remain non-functional. Autonomic dysfunction stabilizes into a chronic condition. Orthostatic regulation remains impaired. Bladder and bowel control require ongoing management. Thermoregulation remains inconsistent. These functions do not fluctuate unpredictably. They remain persistently compromised because the neurons responsible for regulation have been lost. At this stage, plasticity fails, not because the nervous system has lost the ability to adapt, but because adaptation requires intact circuitry and metabolic surplus. Friedreich's ataxia provides neither. Surviving neurons operate at the edge of energetic viability. Attempts at compensation increase metabolic demand and accelerate failure rather than restore function. The biological reason recovery does not occur is specific. Neurons of the cerebellar nuclei, spinal tracts, peripheral sensory system, and cardiac conduction pathways do not regenerate once lost. Mitochondrial dysfunction persists in surviving cells because the genetic defect remains present in every nucleus. Late intervention cannot reconstruct dismantled networks. The final state of Friedreich IS ataxia is defined by preserved awareness with permanent loss of regulatory control. The individual remains conscious, cognitively engaged, and capable of intent. The nervous system cannot reliably coordinate or stabilize action. Autonomic regulation remains incomplete. Cardiac vulnerability persists. This condition can be sustained for years as a stable biological outcome. Friedreich's ataxia is caused by inherited suppression of the FXN gene, resulting in chronic frataxin deficiency, mitochondrial iron dysregulation, and progressive failure of high-energy neural and cardiac tissues. Once neuronal and myocardial loss reach critical thresholds, reversal does not occur. The affected cells do not regenerate. The circuitry does not reassemble. The outcome is continued life with permanent loss of coordination, sensory integration, autonomic regulation, and independent motor control. This is pathology of fear, and this fear is real.